We've talked about how over-medicalisation in death is a problem in our country and how it is causing people to die slow, drawn-out, undignified deaths when that needn't be the case. But what does that actually look like in practical terms? Well, get out your pen and paper, as these are the things that you're going to need to think about when writing your advanced care directive. But before we begin, we post death and dying related videos every Friday, so if that sounds like your kind of thing, consider subscribing to the channel. Now let's talk over-medicalisation in practice. Now, it should go without saying, but I'll state it anyways, that all these medical treatments and interventions have their place in healthcare treatment and can be very beneficial. No one is saying don't use them ever. No one is saying avoid medical treatment. And for the love of anything that's holy, no one is saying to try and cure your cancer with sunflower seeds and herbs instead of seeking actual medical treatment. Thinking like this is why aliens never visit us. But with all that in mind, let's look at the things that will keep you alive in a technical sense, but with no quality of life. Intubation and ventilators. Mechanical ventilators are machines that act as bellows to move air in and out of your lungs. Your doctor sets the ventilator to control how often it pushes air into your lungs and how much air you get. Most patients that have been in hospital at some time or another would have had a breathing ventilator using a mask. These aren't invasive, and these aren't the ones that are problematic at end of life. Because the other version is where you need to be intubated, meaning having a breathing tube put down your throat, which is for when you are in severe respiratory failure, usually when you're not breathing on your own at all. If you are conscious, which is unlikely, but it does happen from time to time, your movement will be limited, your throat will be sore, your breathing tube will need to be cleaned from time to help remove mucus from your lungs. This requires suctioning, which causes you to cough, which means you're in more pain and feel short of breath. There's also a huge risk of pneumonia, lung damage, vocal cord damage, and weakened diaphragm. And obviously, you're not going to be able to eat or drink in the regular way, which calls for feeding tube. There are a number of types of feeding tubes used in different situations. Many of us who have been in a hospital will have had an IV drip for hydration, for example. But the main type that many end-of-life patients get stuck with is the nasal gastric tube. This is for patients who are unable to swallow, whether due to invasive tumour, weakness or neurological disorder. A thin tube is inserted through your nose, down your throat into your stomach. A liquid food formula is given through the tube continuously at a slow rate or several times a day at larger dose, so the body receives nutrition. Now, not sure how many of you have had one of these tubes down your throat for a few days at a time, but I have, so I'll give you a personal look into what that looks like. Firstly, having it put down your throat is unnerving as hell and your body fights it no matter what. Then you are there for days with that something is stuck in my throat feeling, because there is. You are irritated, agitated, you can't sleep, and every time you swallow, you feel it moving. And every move you make requires thought beforehand, otherwise your tube will be yanked from your throat. And I was coherent at the time. I understood why it was needed and that it was only going to be there for a few days. If someone is not coherent, nurses and family need to watch them 24/7 so they don't try and pull it out, because that is all you want to do. Not only that, the risk of pneumonia is extremely high the longer you have it in. Blood clot injections. If you are lying in bed without much movement for a long period of time, your chances of getting a blood clot such as deep vein thrombosis are quite high. So the medical team will likely give you anticoagulation injections, usually in the torso area. Now, that doesn't sound so bad until you're receiving them daily and in the same spot. This gets tiring and painful, being poked and prodded continuously, and studies show that it doesn't really make much difference for those with 1 to 3 months to live. Arterial blood gas testing. An arterial blood gas test is a blood test that requires a sample from an artery in your body to measure the levels of oxygen and carbon dioxide in your blood, as well as your pH balance. It can help healthcare providers interpret conditions that affect your respiratory system, circulatory system, and metabolic processes. You will note that most blood tests that people get on a day-to-day basis are from a vein, and as long as you don't have a big fear of needles, it's not that bad. Unfortunately, getting a blood sample from an artery is usually much more painful than getting it from a vein. This is because arteries are much deeper in your body and often surrounded by nerves. So no matter how good you are with needles, you are likely going to feel lightheaded, dizzy and nauseated while the provider takes blood from your artery. CPR. Cardiopulmonary resuscitation is not what it looks like on TV. It is a violent activity, and to be done correctly usually involves breaking ribs and causing severe internal injuries. Now, for otherwise healthy people who have just experienced a heart attack or an accident, the benefits can outweigh the risks. However, for patients who are dying from life-ending or irreversible illnesses, or have chosen not to prolong life, or who are elderly or frail and easily broken, CPR offers no benefit. Most of us would like to go peacefully, and this is not peaceful. And yet every day dying people have CPR thrusted upon them over and over, often because that is what the family wants, disregarding the patient's wants. Surgery. It is very common for those in last stages of life to be subjected to futile surgeries, often agreeing to it because they don't understand the implications and just sign the form. Many surgeons will convince patients that it is in their best interest to undergo another surgery, telling them that they will give them another 2 months to live, which might very well be true, but 2 months after a brain surgery or taking out half your intestines isn't going to be great, and you die anyway. If you have never had a major surgery, you might not be able to comprehend what you feel like afterwards. But I have had major surgery, and I can tell you it's shit. And being in hospital is not a retreat either. Many people seem to forget that. Treatment. It is common for cancer patients and the like to undergo multiple rounds of chemo, radiation, and other treatments. These all come with numerous side effects, including fatigue, loss of appetite, nausea, hair loss, mouth sores, skin and nail problems. And after going through a few rounds, many patients have had enough. But doctors, in their must-cure-all attitude, will push them for one more round, and then just one more round, even when it's become evident that the patient is done. The doctor may then suggest the patient go on trial medication or treatment. Some may be all for this, others feel like they're being used as a guinea pig. When someone is otherwise healthy and just starting these treatments, their outcome looks good. But after a few rounds with all the side effects, the body is no longer as resilient as it was, and the prognosis gets worse, and the patient ends up feeling like crap. Isolation from families. During the COVID pandemic, the medicalisation of death became even more stark, as many people were isolated in hospitals and their families couldn't visit them before they died. Suddenly there was an uproar about how unjust it was. But this has been common practice in many hospitals' intensive care units for decades, depending on the person's condition. This isolation from family can be extremely distressing for dying patients, and certainly not helping with their quality of life. Quality of life. Individually, these things don't sound so bad, but they add up when you have to have many of them over a long period of time. If you want to have repeated rounds of chemo up until the day you die, that's fine, that's your right. If you have thought about all of this and decided you want to be kept alive no matter what, technically that's your right too. But for everyone else, it is a question of what does quality of life mean to you? Because it's different for everyone. You might say quality of life stops when you lose your sight. For someone else, it stops when they can no longer control parts of their body. The question also means, what do you want to achieve in your last few months or weeks? Do you want to have tried every treatment possible? Or is it more important that you can communicate with your family? Or that you can go outside to the beach just one last time? These are the kinds of things you need to consider. The treatments we have described are common and not pleasant, but they are tolerated by patients all the time when it is likely to be effective. But they shouldn't have to tolerate them when they know it is going to be futile. If you have never had any major surgeries or health problems throughout your life, it is very easy to think of these treatments as being no big deal. But even if you've only undergone one of these things, you will know it's not as simple as it sounds, and can see how long term it would be very difficult to handle. So please consider all of this. Write down what you do and do not want, and then tell your family many times over so they don't forget and there's no confusion should the worst happen. And with that, go talk death.